Ann Cameron. I am a urologist at the University of Michigan, and I also did subspecialty training in female pelvic medicine and reconstruction. I'm also an endowed chair at the University of Michigan. I'm the James Monty Legacy Professor of Urology, and I'm also the vice chair of the department. Outside of the University of Michigan, I do a lot of research in neurogenic bladder and in spinal cord injury and recurrent urinary tract infection treatment and prevention. I'm also very involved in several societies, including the American Urological Association. I've written several of their guidelines on overactive bladder and neurogenic bladder. And I'm also currently the president of the Society of Urodynamics and Female Urology. And I also spend most of my time looking after people with recurrent urinary tract infections as well as neurogenic bladder. So hence the title of my talk. So just to orient you all, these are some Petri plates, and microbiologists do a lot of Petri art where they grow bacteria that can actually look pretty beautiful. And this is to remind us that not all bacteria are bad. We have bacteria on our skin and in our gut that are essential for our life and homeostasis. But today we're going to be talking about the baddies, the ones that are causing a lot of suffering. And this is my disclosures, again, relevant to this talk. We do this in any academic talk. I give you information about me that may bias my opinion. I did receive federal funding for a study on gentamicin, which I'm actually going to cover today. So let's talk about the bladder a little bit before we get started. This is a female bladder on the left and a male bladder on the right, and you'll see that they are very, very similar with a bladder body or detrusor, and then there's a urethra, which is the tube where the urine exits the urethra, and in women, the urethra is very short because the urethra exits in the vagina, and in the male, the urethra goes through the prostate and then out the penis in the urethra. But again, male and female bladders are actually very, very similar. And there are many reasons that people can have bladder problems and bladder dysfunction. But in people with spastic paraplegia and other neuromuscular problems, they can have a regular bladder, a bladder that functions normally. That does happen. Some people's bladders are not affected. But the two major categories of bladder dysfunction that exist are overactive bladder type symptoms. So that's when the bladder muscle is squeezing too hard and causing people to leak unexpectedly. And the other is urinary retention, where that bladder muscle actually doesn't squeeze properly or is weak, and that person doesn't empty their bladder properly and may need to catheterize. So I'm really going to talk about two kinds of bladder dysfunctions that can lead to urinary tract infections. One is retention, and the other is just overactive bladder or voiding or urinating people. So just to orient everyone. And again, the reasons that the bladder doesn't work can either involve the brain, the spinal cord, the peripheral nerves, or actually the muscle inside the bladder. And in other instances, there are other problems such as childbirth, having an enlarged prostate. Those are all other reasons that people can have bladder dysfunction, but just there's a wide range of bladder functioning in these conditions. So let's talk about UTIs. So on this planet, half of all women in their lifetime have had a urinary tract infection. So that is an incredibly common infection that happens in human beings. Of those who get a urinary tract infection, 4 have recurrent urinary tract infections. And recurrent urinary tract infections are someone who's had 3 different infections in a year or 6 in 2 months. So that's what we define recurrent UTIs as. And of all the UTIs that happen on this planet, 85% are from E. coli, and that's the name of the bacterial species that is most typically involved in any type of urinary tract infection in people who urinate on their own. In people who, I'm going to use spinal cord injury as the example, but that's a classic condition where people are not able to empty their bladder and require a catheter or self-catheterization to empty their bladder. The rate of urinary tract infection is much, much higher. So those people on average get 2.5 infections every single year, which is actually a lot. And it depends on how they manage their bladder. Those people who in and out catheterize and don't have a catheter in all the time get 1.5, but those people with indwelling Foley catheters get up to 10 infections per year. And this is the number one reason for people in urinary retention being admitted to the hospital is for urinary tract infections. And there are lots of risk factors on top of that that make them more likely to get urinary tract infections, being female, having a catheter in, having a worse injury, more disability. But most of these are not things that we can change about that person. They're unmodifiable risk factors. So we have to work with the preventative methods that we have and things that we can change. There's no point in dwelling on things we can't change. So why do UTIs matter? And it's this group probably understands this, but I try to explain this to physicians when I'm talking about UTIs and why they really matter. And physicians tend to think of it as a bladder-centric problem. Oh, it's just a bladder problem, but it really isn't. I mean, clearly people with UTIs can develop sepsis, which can be life-threatening. And in people with neuromuscular conditions, they're at much higher risk of developing sepsis with just a regular bladder infection. When people do get these upper tract infections, they can get stones and they can get kidney scarring. They often become wet for the first time and incontinent when they were previously dry, which can be very distressing, limits socialization, and can cause skin breakdown. You have to take antibiotics every time you get a UTI, and that actually changes the bacteria that are in your colon. So you're changing your bacterial flora and your microbiome, which in people with spinal cord injury, they actually get diarrhea with 30% of every round of antibiotics, and they can get C. difficile colitis, which is a colon infection with a really bad bacteria, can be life-threatening. So UTIs are no joke, and they're not just a simple bladder problem. And probably the most difficult problem to deal with is the constant worry. So people who get recurrent UTIs are always thinking, when is this going to happen again? When is this going to happen again? There's often no trigger, no preamble. It just happens, and it always happens on Friday night, or it always happens when you go visit your grandkids in Florida. It's always at inopportune moments, and it can be very, very disabling in and of itself, because how do you prevent these? How do you treat these quickly? Because it's not always easy to take care of. So that can actually be the worst problem. So empowering people to prevent UTIs is probably the best way that I help them deal with those concerns. So if you want to understand why people get UTIs, it's actually helpful to know why we don't get UTIs, because the human bladder is actually a really fascinating organ. So in the urine itself, there are proteins called tame horsefall proteins. And if a bacteria gets in your bladder, they actually bind to that protein, and next time you pee, it gets peed out. Urine is acidic. That is not a great place to grow. The urine is a high osmolality, which means it's mostly water, and it's not a great place for bacteria to grow. And there's no food for bacteria to live on unless you have sugar in your urine. So it's very hostile to bacteria. The cells of the bladder are very, very tight, and they will not let bacteria get in between them to get into the tissue. It's called tight junctions. There's actually antibodies right sitting on the bladder wall ready to attack any bacteria that attaches. And in women, the vagina is where most of the bacteria sit and end up going into the urethra. But in women, the vaginal cells turn over like 3 times a day. So even if a bacteria sticks, they exfoliate so rapidly. The vagina is full of lactobacilli in premenopausal women, which crowd out all the bad bacteria. And it's acidic as well, which is a bad place for bacteria to grow. The urethra, if it's really long, like in men, it takes a really long time for a bacteria to make its way up the urethra, which is why men hardly ever get UTIs unless they catheterize. And then there's something called propulsive flow. So when you pee, your urethra gets a big whoosh and completely cleaned out. So if you have a good pee, you're going to really flush out that urethra. So if a bacteria made it in this far, you're just going to pee it out. So that's how the bladder prevents you from getting UTIs on a daily basis, which is actually pretty amazing. So in people who are at risk of UTIs, there's often different things going on which do put them at risk. They might have not a very stretchy bladder that decreases blood flow to the bladder. The immune response in the bladder is not as good with people with neurogenic bladder. That layer between cells is not as good when you have neurogenic bladder. You might have reflux. That's actually urine backing up to the kidneys, and that's the bacteria can hide up there in between urinations. And if you have no flow because you're catheterizing, you're losing all that propulsive flow protection. The kinetics, how the urine whooshes and flows in the bladder, is different if the bladder is emptying this way rather than, which is, I just did that big hand motion, but that's how urine flows in the bladder when you pee. It makes this huge whirl and empties every little grain out of your bladder. And then you're putting a catheter in. And if you have perineal soiling and perhaps fecal incontinence, you might be introducing some of those bacteria. So that's why people who have neurogenic bladder and bladder dysfunction are particularly at risk for UTIs. So antibiotic resistance is a big problem, and it's becoming a bigger problem over time. And just to explain, antibiotic resistance is not you yourself becoming resistant to an antibiotic. It's the bacteria that you're getting infected with. And in people who get multiple courses of antibiotics, the bacteria that live in their colon become resistant. And those are the most common source of your own bladder infection. So the bad bacteria in your colon are actually making their way into your bladder, and that's how you get a UTI. So each bacteria has its own resistance, and the more they're exposed to antibiotics, the more resistant they get. And when we look at that in your medical record, you'll see here on the left, this is a E. coli. There's a long list of antibiotics. This is an easy one, easy button. You can give this person any antibiotic on that list. There's like 15 of them listed there, and it will treat this UTI. Perfect. But you see here on the right, this is someone who has ESBL, E. coli, bad news, a lot of resistance. And again, some of these antibiotics are only available IV. And if someone has 2 or 3 antibiotic allergies, you may be very limited in how you're going to treat this infection. So that can become a big problem, and I may need infectious disease to help me out. So what we want to do is avoid exposing people to too many rounds of oral antibiotics, because if you're not taking antibiotics in your body, your E. coli that live in your gut are going to be like those guys on the left. That's how our natural state is. When you get exposed to enough antibiotics, your bacteria become resistant. So antibiotic resistance is a big deal. The CDC makes a big deal about this because so many people are actually dying of resistant organisms. Last year, they estimated that almost 3 million people died of infection related to resistant organisms. So it is a very, very big deal in this country. And again, antimicrobial resistance developed over time. And this is just a quick diagram, but basically between the 50s and the 70s, a whole bunch of antibiotics were developed, and it was great. It was a great time to be an antibiotic researcher, because you just had to look in nature and look at fungi and how different plants and organisms fight infection. And oh, I discovered a whole new class of antibiotics. It was brilliant. It was a great time to be an antibiotics researcher. But very quickly, the number of new antibiotics developed plummeted because we've run out of natural reservoirs of antibiotics that existed. And we all know about the penicillin story. And as we started using antibiotics more and more, we started seeing resistance. So in 1965, the first penicillin-resistant pneumonia emerged, and the MRSA was found in someone's skin in 1968, and VRE was found in 1988. So these are more and more resistant organisms. And again, the number of companies actually doing antibiotic research has plummeted because all the easy stuff has already been found. And over in the 90s and the 2010s and the aughts, only 2 new classes of antibiotics have been developed since then, and none since. And again, levoquin resistance was discovered the year it was launched. And now there are strains of gonorrhea that are resistant to all known antibiotics. And there are actually bacteria on this planet resistant to all 26 classes of antibiotics. So yikes, no one wants to develop bacteria in their body that are that antibiotic resistant. So the CDC released this very scary pamphlet if you really want to know more about this topic, but it talks about how antibiotic resistance is going to affect the US and this planet in the near future. But anyhow, it's It's just an important topic, which is why we try as physicians to educate our patients not to overuse antibiotics. So this is how we feel sometime when we're trying to help people and try to treat their UTIs, because we don't want to overtreat. We don't want to give everybody antibiotics all the time and have them develop resistance, but we also don't want people suffering with the symptoms. So this is I live in Michigan. There's a lot of snow here. So this is sometimes how I feel. I think I have that jacket that I shovel snow with. So all right, so there is a great guideline out there on recurrent UTIs. This one focuses on women, but it was by the AUA, and they've just recently updated it. But it's a great document talking about how to use evidence-based medicine on how to prevent UTIs, and I'm going to reference it a lot during this lecture. So bacteriuria is just where you have some bacteria in your bladder that aren't doing anything. And a UTI is when you have bacteria and they are behaving badly. So how do we know bacteria are behaving badly? It's when you have symptoms. So when you have burning, you have urgency, leaking, fever, pain, or in some people, they get spasticity in their lower limbs from an infection. We know those are symptoms that are consistent with a urinary tract infection. And in those people, we would test their urine, probably with a dipstick and a urine culture. And we do need all those things to be positive to diagnose someone with a UTI. Because if someone has UTI-like symptoms, but their culture is negative, they don't have a UTI. They have something else going on. And the opposite is also true. If someone has a positive culture but is feeling fine, that's just bacteriuria. And we're increasingly becoming aware that some people just have healthy bacteria in their bladder, and we can chill and leave those alone. And there's no reason to treat those unless they're pregnant or unless they're having bladder surgery. And we can just leave those alone. And two things that we often don't care about are urine smell, because lots of things can make urine smell, and urine cloudiness, which can be related to bacteria, but is often related to the foods we eat. And those are not symptoms we tend to treat. And again, I just mentioned some bacteria here that you always have to be a little suspicious if that's what you're growing in your urine, because there are bacteria that live in your vagina. Well, if you're a woman, you live in your vagina and they might contaminate your specimen. So there's complicated infections and uncomplicated infections. And the big difference is the complicated infections need to have longer course of antibiotics. So these are people that have a harder time clearing infections. And these are men, because men have a prostate bacteria can get trapped in the spongy nature. And if people don't empty well, then they are at higher risk of, getting reinfected again. So we treat them for 7 days. But for a woman who empties well, she tends to be uncomplicated and can usually be treated for 3 days with antibiotics. So this is the long list of antibiotics, and I've got them listed in order of what is the best to the worst in terms of side effects. So I don't have brand names listed here, but Bactrim, trimethoprim sulfamethoxazole is often a first choice unless you're allergic to sulfa. Nitrofurantoin or macrobid is a great choice. And they're great choices because they don't cause yeast vaginitis, they don't cause gut upset, and they don't cause diarrhea. And they're also at low risk of causing resistance or other side effects. So those are great antibiotics, provided you can take them. Fosfomycin is an oldie that has been resuscitated, and it's a sachet, and one sachet is for 3 days, and very low resistance to that as well. There was a question posted ahead of this, and it was about pivmethicillinam. Oh my goodness, I can't even say it. Pivmethicillinam. And it's a penicillin-derived antibiotic that was just approved by the FDA just a few months ago. And 3 days of that 3 times a day is a very low-risk antibiotic in women. It has been used in Europe for over 10 years. So this is not a huge new development, but it did become FDA approved here. And again, it has a low risk of yeast, vaginitis, and diarrhea, which is great. There are antibiotics that exist that sometimes we have to use. If your culture, I showed you the resistance pattern. If everything is resistant, then I have to use the bigger guns to treat your UTI. And then there are things like Keflex or Augmentin or Cipro or Levoquin, which have more side effects, but sometimes that's what we have to do. So again, uncomplicated is 3 days, and complicated is usually 7 days. And again, we don't test for cure. So if you had a UTI and I treat you, I'm not rechecking your urine to make sure it's all gone. The way I know it's all gone is that you're feeling better. Because if you're feeling better, you don't have a UTI anymore. You might have a few bacteria that persist that your immune system is taking care of. We don't want to keep testing and treating and testing and treating for no reason, because you get into this spiral of overtreatment. And people often ask, oh gosh, it'd be great if you gave me like 2 weeks antibiotics. If you're really like, kill this. And that's, a good idea in theory, but in practice, it actually often backfires. So this was a study done on 40,000 male veterans at the VA, and most of them got prescribed Cipro. So a huge study where they looked at those guys who got given more than 7 days of antibiotics, like, let's treat them really good, and those who only got 7 days, which is actually the recommendation. And the C. diff, so the bowel infection rate, was much better with only 7 days of antibiotics, and it was higher with more than 7 days. But what was actually really important is that there was no difference in cure. So the cure rate was the same. So longer and stronger did not equal a better cure rate. It also didn't change the time to when you got your next infection, your time to recurrence. So those are the things that I care about. If I treat you with just 2 days of antibiotics, that's not enough. You're probably going to recur quicker. We don't want people recurring, and we want them to be cured, but we also don't want to cause harm. So 7 days is enough, even in a male population. And this was a much older population as well. So this was, I think the average age in this study was close to 70. So these, this is a patient population at high risk of UTI and recurrence, and they still got really well treated with just 7 days. So asymptomatic bacteriuria, I like this picture. It's just bacteria just hanging out in your bladder. They're just hanging. They're not doing anything. They're not hurting you. There's often multiple bacteria, multiple different kinds, because they're just hanging out and getting along. And in people who catheterize, it occurs in up to 90% of people. And people who don't empty their bladder completely, it's up to 30% of people. So that's a lot of people. And anything that happens in 90% of a population is probably not abnormal. Like, it's probably just okay. And there are great guidelines out there that say this is not important to treat. You don't prevent future UTIs. You're not making this person any better, but you are giving them antibiotics and maybe giving them diarrhea. And again, the only people who need treatment are if you're pregnant or if you're having bladder surgery, not knee surgery or eye surgery, but if you're having bladder surgery. And again, we're not worried about smell or cloudy urine, and we're not testing for cure. So now I'm going to flip. Now I talked about treatment. So I'm flipping now to how to prevent. How do we prevent urinary tract infections? So my job is to diagnose and fix some anatomic causes. So when there's something amiss, something I can see, something I can find, that's awesome. When I find something that I can treat that actually gets rid of your recurrent UTIs, that's a win. I'm just going to give you some examples. This is the inside of a bladder. This is a woman who had a ureter surgery 20 years ago, and she kept getting the same yucky bacteria over and over and over again. And I looked in her bladder, and this was a stitch that was left behind in her ureter. So she got a whole heck of a lot better when I got a little micro scissor and snippy doo and pulled that thing out. So again, we do investigate for causes of persistent infection, something that's in there where the bacteria are sticking to and not going away. And this was a non-absorbable stitch. This is a patient who somehow got a hair in their bladder and it formed a stone, and getting rid of this stone really made his life a lot better. This is a X-ray of someone having a bladder study, and you see the bladder at the bottom, and those two big arms going up are the ureters. This person has terrible reflux. We should not be seeing the urine going up the ureter tube. So this person is getting recurrent UTIs because their urine's not emptying out of their bladder. It's going up to their kidneys every time they urinate. So that's a problem that needs to be fixed. I can't just give them medicines and cranberry and make that go away. This is also a picture of someone who has a very badly compliant bladder. You can see that their bladder has all these curly cues, and it almost looks like Marge Simpson's hairdo. It's a classic picture of someone who has a not stretchy, very stiff bladder that has little pockets where infections can hide, and that needs to be treated. We often worry about kidney stones. So you see, this is a CT scan, a cross section. I got 2 kidneys on the person's back, and I'm pointing at one little teeny white kidney stone. Little teeny kidney stones don't cause infections. Little specks, those are not things that we worry about, but I do check for them because every once in a while I find big kidney stones. So this is a front view of someone who has stones, humongous staghorn calculi in both kidneys. So both of those kidneys are full of stones. This isn't contrast. That's actually what those stones look like. So these stones are full of bacteria, and they absolutely need to be treated because these are the cause of this person's recurrent UTIs. I've been doing this for a long time, and I just have lots of examples of things that I've found. And again, this is a bladder stone. This is a patient who self-catheterized and kept getting UTIs, and they had a 6 centimeter stone in their bladder that I found on just a plain x-ray. So treating that certainly made him better. But more obvious and more common problems that cause UTIs are what kind of catheter you're using if you can't empty your bladder. This is a Foley catheter. So this is an indwelling catheter. The balloon's not inflated here, but the balloon sits in your bladder all the time and it drains your urine with a bag. And some people have suprapubic tubes. They have a tube going through their belly. They have the same infection risk. It actually doesn't help prevent UTIs. Having something in your bladder all the time allows bacteria to stick. And those people who choose to manage their bladder with clean intermittent catheterization, so in and out, draining their bladder, much like someone would go pee, the UTI rate falls sixfold. So the UTI rate is 6 to 1. So this is a huge reason that people with neurogenic bladder get UTIs, because they have something in their bladder all the time. And again, anyone in the hospital, even for a short period of time, their bladder gets bacteria in it at a rate of 5% per day. So if you have a Foley catheter in for 3 months, 98% of people have lots of bacteria in their bladder. So it's guaranteed that you're going to get colonized if you have a urethral Foley. Some people, I just mentioned clean intermittent catheterization. I thought I'd show you what that is. These are just two examples. The one on the left is a male length catheter. So that's a longer catheter that's about this long that goes in the urethra to drain the bladder. And they also have newer, the one on the right, that's a female pre-lubricated catheter. Sometimes we call them lipstick catheters because you twist and pull, and that little catheter came out of that tube and it's already lubricated and ready to go. And these are often more convenient and more comfortable for patients. But when I'm talking about self-catheterization or clean intermittent catheterization, it's you pass a catheter, drain your bladder, take the catheter out and throw it in the trash. And I'll show you an example. So this is, a female patient who is putting a catheter in her urethra and draining her bladder. And in men, they do the same thing. They expose the meatus, the hole, to the urethra, put a catheter in and drain their bladder. And that's how that's done. So this only introduces the catheter for maybe a minute. And so it doesn't really introduce bacteria the same way having a catheter in all the time. And again, this is just an example, again, of just something gross I saw one day. I took a catheter out of someone and it had been in for 2 weeks. And I'm like, that's gross. What's that stuff? And this is all the biofilm that forms on a catheter. Even after just 2 weeks, it's protein debris from bacteria adhering to that catheter and growing. And that's why you just can't get rid of UTIs when you have an indwelling catheter, because even after 2 weeks, it's already formed this. Some patients even have a worse issue with catheters where that biofilm becomes encrusted and crystalline, and it's very, very complicated to treat. And this is just some examples. It almost looks like a bladder stone inside the catheter that forms very quickly over a couple of weeks, and their catheters get clogged and it's really miserable. And this happens because of bacteria. The bacteria actually raises the pH in the urine, making all the crystals in your urine crystallize on that biofilm, and then you get a clogged catheter. And it's really, really unfun in every way imaginable. So people have tried to invent special catheters to try to prevent these infections. You can impregnate silver into the catheter, and they call them silver catheters. Unfortunately, that's been shown to not be helpful. It's good for like 2 days, but after 2 days, the effects wane. And so it's not really worth it because it really doesn't make a difference and they're very expensive. People have tried putting antibiotics in them and using silicone catheters, but unfortunately, none of those things actually prevent UTIs, and they're kind of just a waste of your money and your health insurance dollars. I showed you 2 different kinds of catheters. The first one I showed you was just a plain silicone catheter that you have to dip in lubricant to put in your urethra, and the other one was pre-lubricated or hydrophilic. And if you touch that catheter, it almost feels like egg whites because it's very slippery and it slides into the urethra better. And I like it because it's less uncomfortable and it's already pre-lubricated, and that's one less step. But there is some evidence that using a pre-lubricated catheter has a slightly lower risk of infection. So you can see here, this is the UTI rate in 6 studies where they looked at ones with the hydrophilic catheters, which are blue and lower rate is better, versus orange, which is the non-hydrophilic. So over a year, you can see in 2 of the studies, they showed that there's just a slightly decreased UTI risk with these hydrophilic catheters. I think that's good news. That's not the primary reason that I prefer them. I prefer them because they're just so much more comfortable for people, and it doesn't hurt as much when they catheterize. But again, when you put all this data together, there is a decreased risk of that. And that's often how I get insurance companies to cover these catheters. I say, hey, this person's had recurrent UTIs. You need to pay for these hydrophilic catheters, and bonus, they're more comfortable. So in terms of UTI prevention, diagnosing people too often, meaning testing your urine every single week and just, checking just in case, is actually not helpful. Diagnosing people correctly does improve a cure, because if someone has, let's say gastritis and diarrhea and their bladder hurts, but they don't have a UTI, giving them antibiotics isn't going to help. So making the right diagnosis is helpful. And educating my patients is probably the most effective way that I actually prevent UTIs, because they know when they have a UTI and when they don't. And taking their antibiotics the way they're prescribed will help prevent future UTIs and help prevent resistance. So there's tons of stuff on the internet, like it's fine if you want to eat pineapple and wear specific underwear, like I really don't care. It's not going to hurt anything. And that's fine, but you're wasting your money. There are some things not to do. Do not overwash the vulva in women. Women are trying to douche and soap and wipes and these wipes and those wipes, and you're actually removing your normal flora. If you think back to my balloon slide, removing the normal lactobacilli that live there is actually putting you at risk of UTI and making your vulva really sore. So overwashing is not the answer. The only thing that should touch the inside of the vulva is water. Just water. No fancy stuff, no perfumes, no things, water. That's it. Okay. Then there's some common sense stuff. It's like, really makes sense. Go pee every 4 hours, whether you cath or not, just go pee. Empty your bladder. Empty your bladder after you have sexual activity, because sexual activity can push bacteria up inside the urethra, both in men and in women. Just go pee afterwards. And don't do any harsh washing. And for people who do self-catheterize, there are little soft wipes to wipe the meatus. Wash your hands first. Wash your hands first and use a lubricant. Don't just put a dry catheter in. And there's no evidence about wiping front and back and hot tubs and bathing suits and wearing these pants and those pants and doing this, and none of those things matter. So please stop shaming yourself if you're getting UTIs. The advice that I give people about wiping is use a different piece for women for the front and the back. Use a piece for the front, use a piece for the back. No kidding. I have never met a woman who didn't do that already. So I just, tell people, like, please stop shaming yourself into this. And wearing incontinence products can slightly increase your risk of UTI, but it is not why you're getting UTIs. You have risk factors. Again, wash your hands. Drinking water. Someone did a randomized control study on water drinking, like women who didn't drink enough water, and they sent them 3 bottles of Evian a day to supplement their water intake, and at half their UTI rate. So it is not an old wives' tale. Your mom was right. Drink more water. You don't have to go crazy. You don't have to drink 8 liters of water a day. But if you're not a fluid drinker, if you're like, oh, I barely drink anything, you probably need to increase your intake to at least 2.5 liters per day. It'll also prevent kidney stones. So 2.5 liters is a good ballpark. There are some non-antibiotic strategies, things like vitamin C, turmeric, black pepper, horseradish, green tea, potassium, calcium, vitamin D. All of them don't work. D-mannose doesn't work, and lactobacilli, probiotics also do not work. So please save your money. These things can do other things. Lactobacilli will help keep your tummy healthy and help prevent yeast infections, but it does not prevent UTI. So I mean, I am all for naturopathic and natural remedies that actually work, but don't waste your money on things that are actually not helpful. So let's get on to the helpful stuff. Cranberry supplements are excellent. There's a product called PAC in cranberry supplements that actually prevents bacteria from sticking to the wall of the bladder. They've been shown to randomized control studies to be effective, and they are part of the AUA guideline. They don't work that well in people who catheterize, but in people who pee, excuse me, cranberry supplements are excellent. The juices also work, but you have to buy the super concentrate stuff at the health food store that tastes terrible, and you need to drink 3 glasses a day, which is about 500 calories of sugar. So I'm not willing to sacrifice 500 calories in my day for cranberry, and whereas the cranberry supplements have the same amount of concentrate. And there's some stuff in cranberry that you may not want to be consuming. It can cause kidney stones, cranberry. There is oxalic acid in cranberry, and it can also interfere with some medicines, the same as grapefruit juice. So the cranberry supplements are usually purified. So I'm pro cranberry supplements. There's also something called methanamine or Hiprex. It's a prescription medication, old prescription medication that got resurfaced based on a number of studies, that well done randomized studies. So it's a medicine that has methanamine and hippuric acid. It's broken down in your urine, and it basically puts detergent in your urine. It's not an antibiotic. It doesn't cause antibiotic resistance. It is a big pill, and you have to take it twice a day, but it does not cause antibiotic resistance. So I am increasingly prescribing this because it works as well as a daily oral antibiotic. So again, if you're trying to avoid antibiotics, this is a great way. Vaginal estrogen for women who are postmenopausal or perimenopausal is excellent. It changes the vagina back to that healthier state where it has lactobacilli and the pH is right. And it also makes the vagina less sensitive. A lot of women with low estrogen in the vagina, when they pee, it kind of burns all the time. And the estrogen helps get rid of that symptom. So it makes it easier to figure out when you really do and really don't have a UTI. Vaginal estrogen preparations are not absorbed in the body. Your blood levels are 0 after starting them. And there are creams and tablets and an E-string that are available. I prescribe probably 10 of these prescriptions a day in clinic because they are so effective. And again, a non-antibiotic strategy. And it has the added benefits of improving vaginal lubrication, improving sexual function, and making your vagina just plain old feel better. And again, because it improves the bacteria. Botox is something I use in people with overactive bladder and neurogenic bladder. It can actually improve UTI risk a little bit by improving how the bladder stretches. So it's not a reason not to do Botox in someone. And so what about antibiotics? You can give people daily oral antibiotics. If those other things have failed and someone is still getting UTIs, you have to do something. In this study that was done on people who were self-catheterizing, giving them antibiotics every single day in a low dose at bedtime reduced their UTI rate by 50%. That's pretty good. But if you got 4 UTIs this year and now you get 2, you still took 365 pills to prevent those 2 UTIs. So you have to decide whether that's worth it or not. So for 3, 4 UTIs, probably not. I meet people that get 20 a year, and then we're talking about being worth it. And it seems that in older populations, it actually reduces them by 1/4. So again, it might not be worth it. So again, I do this, but it's something that I really have to talk with people about whether it's worth it. And in people with indwelling catheters, with a catheter in their bladder at all times, this is how much their UTI rate goes down when you put them on daily oral antibiotics. So not at all. So it doesn't reduce the rate at all. So it's not worth doing. And the AUA guideline recommends against using daily oral antibiotics. So I don't do that. These are the different antibiotics that are often used for prophylaxis. Monoral once a week, Keflex, Macrobid, and trimethoprim, depending on your allergies. And these are low dose. These are baby doses. They're not a full dose. They won't treat a UTI, but you take them at bedtime. And some people take them only when they have sexual intercourse. So they know that that's their trigger. And so maybe 4 to 12 times a month, they're getting about 3,000 milligrams a month of antibiotic. Some people take them every day, and then they're getting a lot, but that's compared to if you're taking a lot of antibiotics. You can kind of, I do a bit of a dose calculation, how much antibiotic you're really getting this year and whether it's worth prevention. Vaccines are a hot topic. There are currently no vaccines in the US that are FDA approved. There is a vaccine called Euromune that was developed in Spain with Canadian researchers. It's an under-the-tongue spray that you do for 30 days, and it causes an immune response. It's pineapple flavored. I've read all of the studies for this. It is with Health Canada. it might be approved this year by Health Canada. I'd be so excited. I'd be so, so, so excited because the mechanism actually works. I've read all the papers. I know the researchers. I'm the editor of a journal. We've published some of their work because it's so good. So I'd be so excited. And again, I'll also talk about some of my work. This is at the University of Michigan, where we use gentamicin bladder installations. So this is when you get to the end. You have no other choices. You've tried everything. We've gone through all the steps that have led to you to this. I'm still getting UTIs. What am I going to do? This is off label. This is not FDA approved. Gentamicin is an antibiotic that's typically given IV. It also comes in an eye drop because it can treat eye infections. We've published 3 different papers on gentamicin installations in the bladder. And again, it's off label. It's an antibiotic that doesn't penetrate through the bladder wall. So when you put it in the bladder, you know, those tight junctions I told you about, it doesn't penetrate through those. So when you test someone's blood levels of gentamicin, when you put it in their bladder, there's 0. So they don't get the systemic side effects. Your bowel is not exposed to the gentamicin, so you don't get resistant to it. And that's a picture of Ed McGuire. He's the guy who came up with this idea, who was my mentor at the University of Michigan. And it's concentration dependent killing. So the more gent you put in their bladder, the better it's going to treat it. Gentamicin, when given IV, can be hard on the kidneys and hard on your hearing. So those are the side effects when you give it IV, but in the bladder, that's not reported. And again, you make a jug of it and you put 30 to 60 cc's. You put a catheter, you have to do it with a catheter in your bladder, squirt the antibiotic in your bladder, take the catheter out, and you leave the solution in your bladder overnight. And so here are all the studies on gentamicin. You'll see my name in there. Actually, more than once. My paper is Cox, Cameron, and Tate. So this is my research on this. And you can see these are people who started on gentamicin. Their UTI rate for a year in blue. This is how many UTIs they got the year before they started it. So, 5 to 6 UTIs a year. And this is their UTI rate after they started on the gentamicin. And you can see pretty consistently 75 to 80% reduction in UTIs. And when you look at resistance, so are these people getting resistant infections? They actually go down because they're not taking oral antibiotics anymore. And this is true whether you have a catheter in your bladder, whether you're urinating on your own and just catheterizing to do this, or whether you catheterize every day. So again, some of this work was done in conjunction with the FDA. Another study would need to be done to get it FDA approved. But again, this is progressive work towards actually proving that this works. And so this is what I get an email about every single day, someone asking me about this. There's some new stuff on the horizon. There are, ideas about putting radio frequency coils in the bladder, using light in the bladder, putting inserts in the bladder that have antibiotics, and people are coming up with so many amazing things, and I can't wait. But just some ideas of what's on the horizon. And again, this is my goal. This is someone's urinalysis. It's a patient of mine who had a UTI a week, and after I put them on gentamicin, this is what their urine looked like. I just put this up to show off because I was so happy for this person because it was just so awful for them. And again, this is another reason to use gentamicin. This is an allergy list. Some people are allergic to so many things, and gentamicin is a very, very, very rare allergy. So almost no one's allergic to gentamicin, so I can still use it in those multi-allergic patients. So, again, my strategy is everyone needs to hydrate. Everyone needs to not wash. Everybody needs to empty and do healthy things for their bladder. For people with indwelling catheters, I teach them a lot about catheter hygiene, irrigating their bladder with saline, or even doing gentamicin in their bladder to help them. And for my person who urinates on their own here on the left, I will try vaginal estrogen and cranberry. Then I'll add some methanamine. Then I'll add daily antibiotics. And if all else fails, I'll go to gentamicin. And in people who have catheters in and out catheters, I'll put them on estrogen and daily oral antibiotics, and then I'll go to gentamicin in them. So that's it. That was a whirlwind, but I'm totally happy to take any questions. And I see Sheila has her hand up, and she's had her hand up. She's been so patient. I'm going to end my slideshow.
I was just simply going to ask about the sprays and the ointments. I've had urinary tract infections since a long time, like since I was a teenager. And I have been one of those people that had recurrent UTIs, and I was on antibiotics all the time, and I get for a lot of different things, but I have, knock on wood, I drink a lot of water also. Like I follow all the things, but I use an ointment now. And I've had I feel like I need to knock on wood before I do, because like I'm one of those people that oh my God, am I gonna get it? Do I have like what I'm one of the, that's
Hmm.
all the time. And for my education is I have a master's in biomedical engineering. I'm not, so I have access to and I wanted to find out how these creams and sprays work. And they just, I think, change the pH. That's a two-part question. My other question is when I have had a UTI and I go to it, usually it's a awful situation, usually when I travel or whatever, and I'm in a different place and not seeing my normal doctor. And I'm being told as a grown-ass woman how to wipe my ass. And I'm given a dip test. And I want to know how you advocate. How does a patient advocate for a bacterial culture to be done? Because I'm also one of those people who don't have E. coli bacteria present, right? So it has to be specialized. And I think that's a hard thing. If there's a secret handshake you could teach us all, that would be great. And
So the AUA guideline for recurrent UTIs recommends culturing every woman who has recurrent UTI. So I think the magic word is I'm a recurrent UTI patient and I have a history of resistance. Can you culture my urine, please?
There you go. That's
So for your standard, 25-year-old woman who gets one UTI every 2 years, yeah, absolutely. Dipstick and give her 3 days of antibiotics, no problem. But for your recurrent UTI and people who've had resistance and people who have neurological conditions, you should be culturing them with a culture. That is like the way it is. And just say, my urologist says I need a culture. That's another one. Yeah. I mean, I don't treat anybody without a culture hardly at all. So
that is wonderful, Shayla. Thank you very much for bringing that out. I really appreciate that. We also, doctor, have a question over in the slide, the chat box that talks about I have pretty bad reflux on one side. Nobody has ever talked to me about surgery. Should I bring this up?
so that's a nuanced question. Lots of people have reflux, and if they are not getting infections in the kidney that is refluxing, it's probably not clinically important. So people who have massive reflux, the picture I showed was massive reflux into both kidneys and a poorly compliant bladder, that needs to be treated. But lots of people had reflux as a baby that didn't resolve. And it's in a lot of people, it has no clinical significance. But if I reflux on the right, and every time I get a UTI, I get kidney infection on the right, then that reflux needs to be treated as an adult. We treat reflux in kids because it affects your kidneys, but beyond the age of 8 years old, the reflux itself doesn't hurt the kidney.
Very good. Thank you very much. So there's also a question or a comment. Currently, I'm taking Gemtesa, and it
Mhm.
works well for overactive bladder.
Mhm. Love Gemtesa. It's a wonderful medication. It's a beta-3 agonist that calms down that overactive bladder, that bladder spasm. This has nothing to do with UTIs, but it's a medication that calms down urgency, frequency, and urge leakage with a virtually zero side effect profile, super safe in older people and people with neurological conditions, because some of the other medicines like ditropan, detrol, they can actually impact your brain. Yee. So,
How
giving
so?
people medicines that cloud your brain somewhat just makes me uncomfortable. And there is theories that people with neuromuscular conditions have a bit of a leakier blood-brain barrier, and they maybe absorb more of those medicines in their brain. So I avoid those medicines if at all possible. Mirabegron and Vibegron.
Okay, that's very good. Thank you very much. So can you elaborate again about the spray with the Health Canada?
Yeah, so it's called Euromune. It is a vaccine that is basically a whole different series of E. coli, different strains of E. coli that are heat killed and are sprayed on the tongue. And you're like, that doesn't make any sense. But your under your tongue is a mucosa. So is your urethra is a mucosa. So you expose your mucosa to that bacteria and you develop an immune response mucosally. And it's less awkward to because you could spray it on your vagina every day, but that just seems weird. So, so it's this under the tongue spray. The studies that have been done on it show the UTI rate goes down by around 85%, which is really fantastic. And there's no side effects. It's not an injection. You're not even swallowing it. The side effects are mostly in people who are allergic to pineapple. So people who don't tolerate eating pineapple, you know, some people get like swollen tongue and lips from pineapple. Those people really don't tolerate it. They probably should have picked a different flavor. But the side effect profile has been really excellent, and it's just revving up your immune system is all it's doing. So I can't wait until this comes out because the side effect profile is so minimal.
That is wonderful, doctor, because we have a really wonderful group of folks that are our Canadian family members as well. And Linda LaFontaine helps to represent a lot of those in Canada. And so I'm sure she's going to put that on her to-do list and to check that out and see where things
And
are.
I originally trained in Canada, so I keep up on Canadian health. So
Okay,
That is
good
wonderful.
stuff. Okay.
Go ahead, Linda. Did you say something?
Oh, no, I didn't say anything. I just said good stuff.
Yeah, very good stuff. Very good
Yeah.
stuff.
Hmm.
So what is the effect of a distended bladder?
So a distended bladder usually implies that your bladder is overstretched. So when your bladder gets overstretched, it's very at risk for infections because it's just not working properly. If your bladder's super stretched out and you go to pee, and you only empty half. If there's one or two little bacteria in there, you don't urinate them out, and then they can stay and reproduce. So having a distended bladder puts you really at great risk of urinary tract infections because the bacteria are there and they're not emptying out. And also that super stretched bladder doesn't have very good blood flow and doesn't exercise its immune function very well.
That is wonderful. Over in the chat box, you may see this long question here, comment with Carolyn. And it says, my daughter used to take that you're gonna have to pronounce that.
Yeah, methanamine.
Yeah,
and
go
the
ahead.
UTIs didn't start up again. She's taking nitrofurantoin daily, cranberry, and 1,000 of vitamin C. Would she be better off on the methanamine? So if someone has a program that works, I really try not to mess with it because people are so bothered by recurrent UTIs, and they're so awful for some people who, you know, and it's always Friday night. Why is it Friday night? Why is it when you go on vacation? I actually know the answer to that. It's because you change your voiding habits. You know, you hold your pee on the plane, and then you don't want to pee in the nasty bathroom, and you hold your pee in the cab, and then you get a UTI, and you might have more sex on vacation. So that's why people always get UTIs on vacation, or you know, you just do different things. So it's always at the worst times that people get UTIs. So if someone is, you know, happy with their prevention plan, that's great. Nitrofurantoin does have a rare risk of pulmonary fibrosis over time, so I prefer not to use it for more than 3 to 6 months at a time, and I switch someone to something else. But my preference is methanamine over the daily oral antibiotics if it's working.
Can I just
If you can
ask-
swallow the pills, they're big.
Can I just
Carolyn,
ask a
Carolyn,
follow-up?
Go ahead. Yeah, please go
Sorry.
ahead, Carolyn.
So what happened was we originally started with methenamine, and when we were trying to eliminate medications, they made the recommendation to stay on the nitrofurantoin. It might have been because I was just afraid of her getting more infections, but one of her other PCPs is saying that after a year, it's not necessarily effective. And so I'm thinking if we come off the nitrofurantoin, would we be better off going back on the methenamine so that we don't develop. She had 13 infections in 12 months. And that was when she was 16 or 17. She's 19
Yeah.
now. And we've been doing
Yes.
really, really well, but she's doing irrigating twice a day, cathing 4 times a day, and with saline, the irrigating, and she's doing really, really well, but I don't want to screw it up. And if antibiotics are not a great idea, then I'm willing to switch.
Yeah. So again, what you just said sounds like great advice. You know, try going off of it, but she probably needs something. It sounds like she's had some kind of reconstruction. She probably has an augment of some sort if she needs to irrigate. So a lot of those people need more than just, you know, just cathing to keep them UTI free.
Well, she wasn't emptying. She could, sometimes we could get 1,100 ounces, or not ounces, mLs of urine because she was holding so much. She just couldn't
Yeah.
empty completely.
Yeah.
So, thank you
So
for
yeah, the
time.
methanamine is very safe. Yeah.
Thank you.
Thank you, Carolyn. That's very important. Did you say, doctor, that the nitrofurantoin is tied to pulmonary fibrosis?
It is. It's rare. It's very rare. But short courses are not risky, but
Okay.
people taking nitrofurantoin every day for months to years are at risk of pulmonary fibrosis, and you need to get pulmonary function testing. If you're taking it for more than a year, you have to get pulmonary function testing done every year because it's irreversible.
Yeah. So are you guys having, if you're taking that, you know, clearly if you're taking that, you need to be checking your breathing. Is it hard for you to breathe? You know, that's the trade-off. So you guys need to consider that and talk to your pulmonary lung doctors, because that could be serious. She
Yeah.
said
And
rare.
again, in someone who already has maybe some breathing issues from their neuromuscular weakness,
Yes.
that can be a really big combo. So I avoid the nitrofurantoin for that reason, unless someone's
Yeah.
allergic to everything else.
Yeah. Thank you so much, doctor. That's very good. I appreciate your telling us that. Do you see any of these other questions down through there?
Yeah, so Bernard asked what the causal relationship is between UTIs and HSP. So it's not the HSP directly that is putting people at risk for UTIs, but the poor emptying. So if you're not emptying your bladder, you're at increased risk of UTI, and anyone with overactive bladder and incontinence is at higher risk of urinary tract infection. So that's the bladder functioning. So HSP, around 25% of people over time will develop some kind of difficulty emptying. They may not need to catheterize, but difficulty emptying, and around 50% will have some kind of overactive bladder. So it leads to bladder issues that can lead to the UTIs.
Thank you so very much, doctor. There's one more question, you guys. I know we could talk all night, and I appreciate everybody being here, but we've got just like a minute till 7. So, doctor, if you don't mind grabbing that last question, and then that will take care of us for the night.
Sure. Someone said, does gentamicin work on Pseudomonas? Gentamicin works on every bacteria because of the way it's delivered, not the IV version, but the intravesical version, because it's dose dependent killing. We're giving it at a higher dose than you can get through an IV. So the bacterial resistance actually doesn't matter, because it's, it's like bleach. If you put, you're not putting bleach in the bladder, but if you put a little dilute bleach, it'll kill most things, but full dose bleach is going to kill everything. So it's the same with gentamicin. If you put a high enough concentration, it will wipe out all the bacteria.
That is wonderful. Thank you so very much, doctor, for being with us tonight. As you can tell, this is a very important issue. It's something that many of our patients with HSP and PLS are fighting and dealing with.